Hello everyone, a very good morning. Today let us discuss on important one-liners or important points from our genetics. It is very useful for your upcoming FMGE exam, NEETPG, and also for your MBBS final year exam in pediatrics theory as well as for your Viva sessions also. Okay, so here let us discuss on today Down syndrome, Turner syndrome and Noonan syndrome, and other syndromes whichever comes or whichever we link and study you can easily remember. Yes, starting off with the Down syndrome, it is the most common genetic cause of your mental retardation, right? Yes, which is the most common this is all your one-liners. Okay, which is the most common inherited cause of mental retardation. It is Fragile X syndrome, right? So most common inherited cause of mental retardation is your Fragile X syndrome. Coming to the genetics of your Down syndrome, 90 to 95% it is because of non-disjunction. It is due to non-disjunction during meiosis, right? That is, you will have Down syndrome is nothing but your trisomy 21. There is an extra chromosome in the 21 thing. Okay, so it is why there is an extra chromosome. This extra chromosome is due to the non-disjunction during your meiosis. That is, this chromosome doesn't split apart. This is because of your, it is mainly due to your maternal origin. So this is due to non-disjunction during meiosis, which is of maternal origin. While in 4% of cases, it is due to translocation. So translocation, the most common translocation will be between 14, 21. Okay. If a parent, when you take a karyotyping, when you do a chromosomal study, if you find the child is having a translocation, then you have to do a parental chromosome study. That is, for both mother and father you have to do a chromosome study. Why? To know the recurrence risk. Fine. So when you do a parental chromosome study, if you find the mother to be the carrier, what is the risk percentage or recurrence risk? So recurrence risk percentage will be around 15%. If father is the carrier, then the recurrence risk percentage will be around 3 to 5%, right? So these are all your one-liners. They can ask questions like, if there is a translocation in the mother, what is the fetus getting the percentage of risk percentage of the fetus being affected with Down syndrome? That can be your question. So these are your one-liners, 15% and 3 to 5% on. Okay. Yes. If suppose the translocation is between 21, 21, then the recurrence risk is sure the child will have Down syndrome is around 100%. If the translocation you find it to be between 21, 21, the recurrence risk is around 100%, right? Yes. The remaining 1% can occur due to your mosaicism. Here in mosaicism, if the 1% of the chromosomal study is due to mosaicism, then the phenotype will be a milder form, right? Yes. So just to recap on genetics, 90 to 95% of the cases it is due to 90 to 95% it is due to your maternal origin due to your non-disjunction during meiosis, while 4% is due to translocation. Among translocation, it is your 14, 21 is more common. Yes, and 1% is due to your mosaicism. Next, coming to the clinical features. Clinical features very easy. You have to remember from head to toe. If you remember it by head to toe, it will be easy for you to remember everything, every points, right? Yes. Head. The child have developmental delay. Microcephaly can be present. There will be flat occiput. The child can have a delayed closure of your anterior fontanelle. Fine. Yes. Coming to faces, it will be a dysmorphic faces. That is, in eyes, you can have a mongoloid slant. This is your mongoloid slant. What is meaning of mongoloid slant? That is your inner canthus. Your inner canthus will be lower than your outer canthus. This is your mongoloid slant. That is a pseudo A shape. This is A shape. Pseudo A shape. That is your mongoloid slant. Right? That is your inner canthus is lower than your outer canthus. Next, there will be your epicanthal fold. Epicanthal fold is nothing but a skin fold of your upper eyelid covering the inner canthus. So skin fold of your upper eyelid that is covering your inner canthus, meaning your epicanthal fold. Other finding will be your brush field spots. What is brush field spots? That is white spots in iris that is occurring due to the occlusion of stroma. These are your white spots in iris, which is occurring due to your collection of stroma. These are your brush field spots in iris. So in eye, you will be having mongoloid slant, epicanthal fold and brush field spots. Coming to the ear, it will be a low set small folded ear, which is a dysplastic ear. So it is a small dysplastic low set ears. Coming to the neck, it is a short neck. There will be an increase in the skin fold. In extremities, in upper limb, you can see a simian crease can be found and you will have clinodactyly. What is clinodactyly? That is your fifth finger. That is a little finger which is curved inwards. That is called your clinodactyly. So in extremities, in upper limb, you will be finding your simian crease. That is a single palmar crease. Then there will be clinodactyly. Next, you can find a short metacarpals. Okay, coming to your lower lip, you can find sandal gap. What is called as sandal gap? That is an increased gap or wide gap between your first and second toe is called as your sandal gap. Okay, next, in CVS, the most common organ affected in children with Down syndrome, that is 50% of the children in Down syndrome, they will have CVS defect. The most common among them is your endocardial cushion defect. ECD is nothing but your endocardial cushion defect. Then comes your VSD, then will be your SD. These are the most common CVS finding in a child with Down syndrome. Okay, among ASD, the child will have most common will be your ostium primum ASD. Ostium primum ASD. Next, coming to GAT, the most common defect in GAT will be your duodenal atresia. So duodenal atresia will be the most common defect. Other defects that can occur in child with Down syndrome are your Hirschsprung's disease, the child can have annular pancreas, TEF, tracheoesophageal fistula, and imperforate anus. So these are the other findings in GI tract in child with Down syndrome. Coming to musculoskeletal system, the child will have pelvic dysplasia. Right? Yes. Next point will be the atlantoaxial joint subluxation can occur in the child. So atlantoaxial joint subluxation is most common to occur in children with Down syndrome. Okay, and mostly in child with short neck also. Right? These are the most common finding in your musculoskeletal system. Others will be your hypotonia, poor Moro reflex. So Moro is a very important question both for your FMGE, NEET, MBBS, and also for MD Pediatrics, Viva session, and also for your theory exam. So let's discuss on our Moro reflex separately, right? Yes. Next, the child will have an increased risk of hypothyroidism, and also the child will have increased risk of your leukemia. So the most common leukemia in child with Down syndrome is ALL, but the most specific one will be your AML M7 type, that is your acute promyeloblastic leukemia. So your acute these are your one-liners. Promyeloblastic leukemia is the most specific one to be found in your Down syndrome. Then coming to all your one-liners from your prenatal screening. In prenatal screening, you will be do your antenatal USG screening. You will be doing it. In antenatal USG screening, you have to screen for your nuchal translucency. What is the meaning of nuchal translucency? That is your skin fold thickness around your neck. That is called your nuchal translucency. If it is more than or equal to 3 millimeter, if the NT is more than or equal to 3 millimeter, it is suggestive of Down syndrome, right? Yes. What are the other findings you can find in your antenatal USG if you suspect the child to have Down syndrome? One is your absent nasal bone or hypoplastic nasal bone. Absent or hypoplastic nasal bone. Second will be your short femur. Third will be your echogenic focus in heart. Echogenic focus in heart. These are your other findings that you can see in antenatal USG screening of your child with Down syndrome. Next, coming to our first trimester, what are the tests you can do in first trimester? You have what is called combined test. Combined test is nothing but your antenatal USG, that is showing your nuchal translucency, and your double marker. In double marker, it includes your beta HCG and your pregnancy associated plasma protein. Here in Down syndrome, beta HCG will be high, okay, and your pregnancy associated plasma protein will be low, right? So beta HCG is high and pregnancy associated plasma protein will be low. This is your important one-liners. Next, coming to your second trimester, you have two. One is your triple test, another one is your quadruple test. In triple test, it includes your beta HCG. Next is your alpha fetoprotein. Another one will be your unconjugated estriol. These are your triple tests. That is, your one is your beta HCG, second one is your alpha fetoprotein, and third one is your unconjugated estriol. Here beta HCG will be elevated, alpha fetoprotein will be decreased, and your unconjugated estriol also will be low, right? Coming to your quadruple test, it includes your beta HCG, AFP, unconjugated estriol. Another one will be your inhibin A. This is the other test that is added to your quadruple test. So in quadruple, it is four things: beta HCG, AFP, unconjugated estriol, and it is your inhibin A. Here inhibin A will be elevated. So to remember it easily, you remember it as high. What all will be high in child with Down syndrome? It is H for your beta HCG. So high is your beta HCG, and for I it is your inhibin A. So these are the things that you can find in a child with the Down syndrome. Okay. Next, this is another important one-liner for you. Syndromes with normal IQ. So what are the syndromes? So this covers your main important one-liners from your Down syndrome. Okay. I'll share the PDF in our WhatsApp group and Telegram group also. Right. Syndromes with normal IQ are your Turner syndrome. One is your Turner syndrome. Another one will be your another T. It is your Treacher-Collins syndrome. Okay. So coming to your Turner syndrome, your genetic defect is 45XO. That is your absence of your X chromosome, that is due to loss or during your paternal gametogenesis. So why there is an absence of your X chromosome? It is because due to loss of X chromosome during your paternal gametogenesis. So there's a loss of X chromosome during your paternal gametogenesis, right? Yes. So what are the features you can find in a child with Turner syndrome? During infancy, the child will have lymphedema in your hand and feet. Okay, there will be a lymphedema in hand and feet due to a lymphatic obstruction. In neck, the child can find to have cystic hygroma. In face, the child will have a triangular faces or with a high arched palate. You can find the child to have high arched palate. Low posterior, this is your low posterior hairline. In neck, it is your short and your webbed neck, right? Ears, the child will have sensorineural hearing loss, can be found in the child with Turner syndrome. Chest is nothing but wide chest with shield shaped chest with wide spaced nipple. The child will have shield shaped chest with widely spaced hypoplastic nipples. CVS, most common will be your bicuspid aortic valve. Then you can find the child to have coarctation. Most common will be bicuspid aortic valve. Then will be your coarctation of aorta. Most common cause of death in Turner syndrome, this is another one-liner. It is due to your coarctation of aorta, right? Yes. In extremities, the child will have increased carrying angle, which can be more than 135 degrees. So there will be an increase in your carrying angle. So that is your cubitus valgus, this one. It is your cubitus valgus. The child will have streak ovaries. So it is the most common, not most common, it is a cause of your primary amenorrhea. In kidney, the child will have your horseshoe shaped kidney. Yes. Bony abnormalities are the child will have short fourth metacarpal and your medial tibial exostosis. And the child will have a normal IQ. We have found syndromes with normal IQ are your Turner syndrome and Treacher-Collins syndrome. Child will have a normal IQ or suboptimal IQ. The child will be present with that, and child can also have learning disabilities sometimes. So bony abnormalities are short fourth metacarpal and medial exostosis. These are the main points you need to know in a child with a Turner syndrome, or if they ask a question in Turner syndrome for you, even for your theory exam and also for your viva session, right? Yes. Next, Noonan syndrome is which are the phenotype of Noonan syndrome will be somewhat similar to your Turner syndrome. So they have similar features. To Turner syndrome. Here the genetics is autosomal dominant inheritance due to defect in your RAS kinase pathway. So there is a defect in your RAS and MAP kinase pathway. RAS and MAP kinase pathway is a defect in which the genes affected are genes that are involved in this are your PTPN11 gene. PTPN11 gene are being involved in the child with Noonan syndrome. The hallmark or phenotype of this somewhat similar to Turner syndrome. The child will have short neck, webbed neck, low posterior hairline and low shield leg chest will be present. It is most commonly seen in boys compared to girls. Here the child will have what you are called as anti-mongoloid slant. So mongoloid slant is present in your Down syndrome. Here the child will have a anti-mongoloid slant. Okay, and the child will also have hematological abnormalities. Hematologic abnormalities like von Willebrand disease and your coagulation defect. Okay, the most serious the most common will be your pulmonary stenosis. Okay, so these are the most common or important points in child with Noonan syndrome. You have to need to know for your one-liners or for your FMGE and your NEETPG 2026. Yes, thank you.